years. Started with emergency medicine, and over the last probably 5 or 6 years have become involved in urgent care. So kind of my specialty is documentation, and as Dr. Parks just said, you know, the chart and the record serves many masters, I like to say. We're going to talk about what's needed for reimbursement, but I'll also talk a little bit about why it's needed, and we're not just trying to get our dollars, but we want to protect our dollars, because we have not only government payers, but we have private payers that audit the work, and they do things like down coding, and I'll explain what that means. So just to start off, the services that you provide, and some of this I'm sure you all are aware of, but I just kind of want to give a basic background on what you're doing. And we're billing for your evaluation and management services. So that's the meat of what you're doing. That's the entire encounter. You might, you have labs and x-rays and the workup, but the main code that we're billing for is your evaluation and management service. And in the urgent care setting, there are 2 different types of patients. So we have 2 different code sets to use, and I'll talk about that. And each of those code sets have specific requirements. And what that means is you're doing all of this work. Let's say you have a moderate acuity type patient in the urgent care center, and you're working this patient up, but you forgot, or you didn't forget, you just didn't document one element. That could change that service that was rightfully, let's say, a level 4 service, a moderate service in the urgent care, and drop it all the way down to a level 2. Maybe a 3, depending on what you're forgetting. So that's why it's so important to document all of these things. So in order for us to even capture that evaluation and management service, there are 3 key components: the history, the physical exam, and medical decision making. Medical decision making is also wrapped into the medical necessity of the service, which is really important from an audit standpoint. Depending on the type of service, so whether it's a new patient or an established patient, we need either 2 or all 3 of those to even assign an evaluation and management service. So if for some reason there's part of your history that's just missing, that would be a circumstance that we'd have to query the chart back to you, because the ROS is missing entirely. We couldn't even capture that for the higher level of service because we are missing that history. And again, medical decision making is what's driving that overall level. So that's kind of telling the coder, and then we'll tell anybody else who's looking at the chart from an audit or reimbursement perspective, how much work went into this encounter, how much you did both physically and cognitively. So it's really important we get that in there. So talking a little bit about new and established patients. So there are 2 different types of patients that you see in your urgent care clinic. Your new patient, which means you haven't seen the patient within the past 3 years, and your established patient, which means someone within your group, either yourself or someone within the group, has seen that patient. Now, the reason this is important is there are 2 entirely different code sets that we have to use. So CPT codes for those evaluation and management services. And not only are they just different numbers, but they have different requirements. So your new patient requirements from a documentation standpoint are a little bit greater than your established patient requirements. And then we'll also go in and talk about the risk and medical decision making. So talking about a new patient, and you definitely see new patients in your clinics. You'll see over here the new patient grid. So when I'm talking about requirements, I'm talking about HPI, review systems, past family social history, and the exam. So your history, in that previous slide, if you remember, I said you needed 3, either 2 key components or 3. For new patient, you need all 3 key components. So you need a history, you need an exam, and you need obviously medical decision making. Your history is your HPI, your review systems, and your past family social history. Now, the requirement there, and I'm going from level 3 up to level 5. Typically, what we see in the urgent care and the types of patients you're seeing are falling in the 4 for the new patients. Sometimes a 5, not frequently a 5. That's a really high acuity patient. But typically, your new patients should be falling about in the 4. But you'll see the requirements there for a level 4 is 4 HPI, And you all know all the different HPI elements, you know, location, patient comes in with chief complaint of abdominal pain, what's the quality of it, the duration, the timing, you're just explaining what's happening with that chief complaint. And in order to code up to that level 4, we need at least 4 HPI elements. For the review of systems, you need at least 10 systems. So that's one area that we do see some down codes in the urgent care setting here with this group, is not capturing all 10 review of systems. Past family social history, 3 of 3. That means we need a past medical history, we need a social history, and we need a family history. So you need all 3 of those in order to qualify for that level 4. And then the exam, that's one area that we rarely see down codes in the urgent care here. Your documentation is really good on the exam. For that higher level, you need 8 organ systems. You'll see over here on the 4, history and exam is comprehensive, which is what I just described, yet the medical decision making is moderate. So that's the difference between that level 5 service and that level 4, and I'll explain kind of what I mean by that as I go on, some examples of what qualifies for that. But that level 4 is a moderate medical decision making, yet it carries quite a large amount of history and physical and past family social history documentation requirements. So that's kind of where we see the most of the downfall, is in the review of systems and that past family social. So those are the 2 areas I would say across the board, and when I get to established patients, we'll talk about it, where, you know, whether it's that amount of history hasn't been taken, or you just haven't documented all of it, that's where we'll see a level 4 that'll drop down to a level 3. Now the HPI, we really don't have, in all the charts that I've reviewed, really don't have a problem with the HPI. You guys do a great job of that, which is a good thing, because if we don't have 4 HPI, we're going to drop even lower than that 3. You're going to go down to a level 2. And again, this is truly the work that you've been doing, and just forgetting to add one element or forgetting to document that element. You probably did it, you asked the questions. It's just making sure that you're documenting everything that you're doing. So, hold on there. Established patients. You'll see, here's another area where I think we have quite a bit of opportunity. Sorry, I'm talking with my back to you. You know, again, a level 4 service in the urgent care setting is a lot of what we see. We see 3s and 4s. I didn't add the 3s up here because I really haven't seen any documentation issues with your level 3s. It's going up to the level 4. And what we're seeing, actually in this one, is every once in a while the HPI, not a huge issue. Your ROS, as long as you have at least 2 pertinent systems, we're going to be able to capture it. And the past family social history here is much easier. It's one of the 3. Believe it or not, there are times where that's not on the chart. You know, we only need 1, and I'll show some examples of what's considered acceptable as a past family social. You know, past medical history should be easy to get. Social history should be easy to get, but sometimes within the electronic record, the way that it's entered isn't something that we can use. So, again, not a huge issue here. It's more on the new patient side than the established, but it's good for you to know exactly what the requirements are, and then we'll start to go into some detail. Obviously, MDM is used as the driving factor. So in established patients, this is an area where only 2 of the 3 are needed. So that this means if you didn't take a history, but you had a physical exam, and obviously you have medical decision making, we can code that chart. So let's say, you know, your medical decision making was very documented, very low. You didn't have differentials in there. You didn't tell us the story. Yet you had a comprehensive history, and you had a comprehensive exam. We're still gonna want more of that medical decision making to drive that level of service. That's where the medical necessity comes in. So it's important to discuss and talk about your medical decision making. We'll talk a little bit more about that. So, 2 of the areas that I was talking about that we're seeing issues with are the review of systems and the past family and social history. This is where it's really important to be specific. Avoid generic statements, so no significant family history. tie your family history into what the patient's coming in for, the chief complaint. You know, if you're taking, and again, for this higher level of service, the 99204, where you need all 3 of 3 patients coming in with something, and you're taking the family history is pertinent, you want to tie that in with the chief complaint. Again, being specific really helps, especially with EMRs. There's a lot of there's macros being used, and you're clicking boxes, and sometimes it's really hard to get patient-specific information into it without free texting, but this is one area. Also with the review of systems, you can use, if you're doing a comprehensive review of systems, which that means you're reviewing at least 10 systems, and that's what you need for that level 4 service, you can individually document all the systems, or you can document your pertinent systems and then state all other systems reviewed in negative. That is acceptable by most payers. It is acceptable by CMS, and so that's kind of when it comes to an audit perspective, that's kind of what you want to look at. So depending on your practice style, you can do it either way, and that kind of lessens the burden of the ROS. If instead of having to list every single ROS out, you list your pertinence, and then you can use that statement. If you're not comfortable using that statement, that's fine as well, but that is an acceptable statement. And you can't see it here, but in what I do have highlighted there is some of what is recorded in your EMR. And for something like social history, it'll say no record of social history recorded. That doesn't, did you take it? You know, that doesn't mean anything from a coding perspective. You know, it's social history, you know, or smoking, drinking, physicians, who they live with, family, that type of thing. And so I don't know if that's just a macro or the default within your EMR, but it's important that whatever you're documenting there has to actually be pertinent, and just, you know, no social history recorded. And it's very EMR driven or EHR driven. Any questions? Also jump in with any questions as we go along. Do you guys know what I'm talking about when you're doing the social history or any of these where it just says no record, no social history documented?
It's a filler box. It's just supposed to let us know that it hasn't been done yet.
Okay.
So that's what happens if you don't do anything.
Okay.
But it's supposed to then be done.
So we see that. We see that frequently. And again, that's the area, that past family social history, where if it's a new patient and you need to be at a level 4, meaning you've provided a level 4 service, we can't get there because that social history is not there, or the family history. Past medical history is usually there.
On the ER side, a while back, we had put high language in that said we reviewed the agreement from nurses' notes because they included the social history. We need to have something similar in the urgent care world.
Absolutely. If the nursing notes have, as long as you have all the histories there, so if the nurses always take a social history and you add review and agree with nursing notes, we can use it, and you won't be downcoded there.
We added a box in the EMR, but I don't think we have one in the server, which would be helpful to other people. We have to do that? If the nurse enters social history, no smoking, for us to get credit, we have to put something about
Yes.
It
It has to, absolutely.
It always has it.
Alex has it, and IBEX has it.
Well, actually, the PowerWorks, the inmates enter the information, it's supposed to pop up in our charts. It doesn't say they entered it, it's just there. So it doesn't, you can't, looking at the chart, you couldn't tell who entered it. It's just.
That's if you include that in your note, right?
Right. But it's supposed to pop in if you preset it to pop in.
If you choose it to pop in, so that's doable. That's okay, right? Because it shows up in our note that it's something that's just in there, even though it's entered by somebody else.
As long as you're looking at it and you have to click it to actually bring it into your note, yes. There's no way anyone's going to argue that you didn't look at it, and if you didn't agree with it, I'm sure you wouldn't push that button.
We just make sure everybody's on board with getting those set up.
Yeah, and that's really from a lost revenue standpoint, that's really the biggest hit for these urgent cares, that all of them kind of have that same issue. HPI, like I said, it's It's rare, but we do see some down codes. It's really this past family social history. And again, it's a level 4 service. It's really one of your higher levels of service. I'm not talking much about level 5s. The same requirement is for a level 5. The only difference is that's a medical decision making of high acuity as opposed to moderate acuity. So your really sickies that you're probably sending off to the ED would end up at a level 5, but your documentation is the same from a standpoint of HPI and review systems.
So I see here, our EMR right here for the PowerWorks, it has an automatic button you can push that says no significant family history. So I see you don't want that there, but let's say someone's just coming in for a URI. I mean, no significant family history would be the best choice, but you want family history negative for.
So that's a great point. No significant family history. I'm putting that up here, good, better, best. So if it's a URI and that is the best choice, meaning, you know, it doesn't really matter if mom or dad has, you know, a respiratory infection as well, then that's, nothing's being down-coded there. My point here is you want to be as specific as possible. And so in a case, let's say a patient came in and it's, you know, abdominal pain or chest pain or something that you're thinking a little bit more severity, the acuity is a little bit higher, instead of being in the habit of no significant family history, just try to keep in your mind specificity.
What if you just said family history is non-contributory?
So I am not a lover of non-contributory.
Because let's say they're there for an abscess. Family history has no, you know,
Right.
no bearing on that.
Right. So in that case, I actually would rather have no significant family history, because at least it's saying you've made that decision, that you've asked about family history and it's not significant. Non-contributory, and this has happened in audits before, a level 4 service, because that is the most utilized service in the urgent care setting, as well as, you know, we share these codes with offices as well. So your pediatrician uses these, your GP, anybody who's in the office setting uses these codes. So level 4 is a high utilized code, and so it tends to be audited more often than a level 3 or a level 2. Non-contributory, the argument that comes back from payers, whether it be private, more so government, is non-contributory, you didn't ask the question, or non-contributory to the chief complaint. So as silly as that sounds, my standpoint is I'd rather just have a bulletproof chart. You know, you don't want to document anything you didn't want to do. You don't want to document anything that's not clinically appropriate. And so in the case where it really wasn't that, you took the history, but it wasn't significant to what you're treating the patient for, then no significant, it's just less arguable. You know, it's a little bit more bulletproof. Now again, we're not down coding anything. If there's non-contributory on the chart, you're still getting credit for it because you've asked, you have something documented. Same thing with no significant family history. It's just the good, better, best. I'd rather have a bulletproof chart and make sure, you know, if it comes back through for a payer down coding. And what payers do is, you know, Medicare right now is doing down coding on certain levels, higher levels of service in different practice lines. Private payers have jumped on that bandwagon as well. And there's some what we call bad payers out there that they will take, you know, we bill them for your services and they'll say, okay, it's a level 4, we're just going to down code it to a level 3. Because we don't think it's a level 4, even though they haven't seen the chart, because it all goes electronically. And that's what our job is to say, wait a minute, we billed it at 4, now we need to support that and appeal that. And if it comes to an issue where there are multiple charts that are being down-coded, it's usually a sit-down with their coders, sometimes their medical director, and that's where protecting those dollars and just not having anything that is ambiguous in your documentation really helps to support, because you already did the work. That's the thing. You've done the work. You saw the patient, you treated the patient, you've spent the time doing all this, and so as silly as a single word, I'd rather have it kind of be a slam dunk than have to really argue over it.
Excuse me.
Mm-hmm.
I think it's very helpful to know which part of the, so no, can be done by the MA or the nurse, and which one has to be done by the provider.
That's a great point. So as far as your HPI, that has to be done by the provider. Your physical exam has to be done by the provider. Review of systems and past family social history can be done by the MA or the patient themselves. But if that's the case, you need to then review that information and agree with it. So the question about I've reviewed and agreed with the nursing record, as long as you have that within your record, if somebody else, meaning the MA or even the patient, I don't know if you have a patient intake form that, you know, they do their own ROS, but if it's the MA that's doing it, as long as you've reviewed and document your review and your agreement, we can count that. Your HPI and your physical exam you have to do yourself, obviously, as well as the medical decision making. That was a great question. The other thing I want to point out is something that we see with the past family social history is we can pull up a record and we can see that there is, you know, the health status is there, past medical history, past surgical history. Looks like that all counts. So there's 3 different things documented, but that all counts for your past medical history. So a few times, and again, if we're looking for the 3 of 3, we need the family history and social history. So just be aware that, you know, if you've got your health status, your allergies, your past medical, and your surgical history, all counts as just the past medical portion of your PFSH. Any questions there? So, examine HPI, I'm not going to go over very much because this isn't really a problem, but I did want to show you what the requirements are. You can see for all of your higher levels of service, established and new patient, you need the 4 HPI. For the level 3, you actually need it as well on the new patient. The 4 and the 5 on the new patient, your 10, your 3 of 3, drops down to 1 of 3 on that past family social history with established patient. Again, not huge issues there, but where you really live are in that 04 and that 14. Your patients are in the moderate. You have quite a few 3s as well, and we'll talk a little bit about those, but we don't really see any documentation issues with your level 3 services. We're not having to downcode anything. You're not really missing anything with those level 3s. So let's talk a little bit about what we consider, how we get to these levels, what type of patient. So straightforward or low severity patient. Remember that a level 4 service in the urgent care is moderate. So a patient that comes in and needs no studies, you're not giving any meds, there's no prescription on discharge, maybe you've given them a tetanus shot and that's it. That's going to be your lower levels of service. Most of these in the urgent care setting, based on the workup that you're doing, and your past medical history, HPI that you've given us, most of these fall into that level 3, either 03 or 13, depending on the type of patient. So again, straightforward, low severity, no ancillaries, no meds are going to fall into this. Now, when we go into moderate complexity, again, this is where I'm saying this is where most of your acuity lays. And so a patient who comes in with multiple presenting complaints, so your patient is coming in and they have a headache, and they have a sore throat, and they're coughing, you're doing re-examinations on the patient. Most of your pregnant patients that are coming with any other type of complaint will fall into that moderate complexity. If there's any type of psych eval going on, all of these is raising the level of medical decision making. And so it's really important that all of these things are documented. So when I talk about you documenting your medical decision making, that is all the work that you're doing, not just the physical work, meaning I ordered the labs, I ordered the x-rays, I interpreted this. It's also your thought process. So differential diagnoses are important. Kind of the thought process behind what you're doing. If you think about you're telling a story, when I said that your record serves many masters, it's not just for reimbursement, it needs to tell the story. So if somebody after you picks up that chart, they understand what's going on.
Excuse me.
Sure.
you know, our system is set up in such a way that we print instructions to patients that have a lot of information.
Mhm.
Would that be counted against that? Or do we have to document like everything?
So you don't have to document absolutely everything, you just need to document what's the pertinence. Giving aftercare instructions is absolutely important, but that doesn't really count towards your medical decision making. Your medical decision making is really all the work that's done from the time the patient, comes in and what you're working up to get to that diagnosis. So patient comes in with, a sore throat, and your physical exam and all the work you do leads you to X diagnosis. That's what all that medical decision making is, that's really counting towards that visit. Moderate, if you're ordering any labs, give a nebulizer treatment, cultures, and of course this isn't all inclusive. I'm just giving examples so you kind of know what I'm talking about when I'm saying that this is kind of your level 4 services. If you're giving any meds, that falls into a moderate decision making. So if you're prescribing, you're sending the patient home with an RX, that's definitely moderate medical decision making. So you want to make sure all of that is in the record, so we can capture it for you. So back to medical decision making, and the reason I harp on this so much is because medical decision making ties in with medical necessity. And truly, medical necessity isn't something that I can determine. I am not a clinician. I'm a coding individual. So it's important that, and this is what CMS and payers say is, medical necessity is the driving force. It's the reason there has to be proof of medical necessity for that lab test, for this, for that. And so we do that with medical decision making or documentation of medical decision making. So that's why it's important if you're ordering something, why you've ordered it, or that's where those differentials are important. And I'm not talking about a laundry list of differentials, where patient comes in with a chief complaint and there might be 50 differentials, but you're the provider, you're the clinician, you walk in the room and okay, I'm really, I'm looking at the patient, and there are 3 that are really pertinent that I'm thinking about. Document those. Document why you ruled something out. All of those things are very important, and of course documenting everything that you're doing. So if you're ordering tests, if you're interpreting any of those tests, even if we're not billing for them, we're not billing for x-rays, we're not billing for that. If you did look at so not so much from the reimbursement standpoint that we're not capturing those, but it is, if you're making a decision based on the results of a test that you've ordered, that's your medical decision making. So it's important that you document that. All the meds that are given are prescribed. It's important to have that. Is the patient getting better? Is the patient, not improving the way that you wanted them to? Document that. Your re-examinations, all of the stuff that. So really, the slide means all of that stuff that's going on in your head needs to also get into that chart. And I'm not talking about paragraphs and paragraphs, but just the pertinence about what you're thinking. And again, if you had somebody else looking at the chart, say you were looking at the chart and you didn't have some, maybe it's not you, someone's looking at the chart that doesn't have your clinical expertise, why was this done? And if you can kind of get that mindset into your documentation, your medical decision making, and again, not having to tell me why you ordered absolutely every lab test, but just why you went down that path. That really, really helps support your overall level of service, which again is what you've already done, and then it helps protect that chart should it be audited. Any questions about MDM?
One side note.
Sure.
If you now know that there's a pertinent family or social history relevant to the patient's complaint, and you include it in the HBI, will that be counted against the family and social, or it has to be?
So if you document the family social history within your HBI,
that's the chief complaint in the HBI, would that be counted against that you
counted towards?
Fulfilled?
Yeah.
Fulfilled.
It doesn't matter where it is in the chart as long as the information is there. It's nicer to have it in a succinct manner. But if you are the type that takes your HPI and does your review of systems within your HPI and just kind of does one big paragraph, as long as the information is there, we can use it. It doesn't have to be under a specific heading. That said, if then you go down to your final discussion, that's a little bit harder to pull out or to argue that, hey, this was social history or not really social history, but that's part of the HPI when it could be just part of another discussion. So if things are within that whole HPI section, you can usually grab them without a problem. We don't ever want to have you double document or be repetitive. You should only have to document it once. Any other questions about the overall levels of care before I move on to procedure documentation? Quiet group.
Well, let me throw in something.
Okay.
How soon in an urgent care setting, if a patient comes to follow-up, would be considered a follow-up visit rather than a first-time visit? Or how does that work?
So if that's where that 3-year gap comes in. So
Even in the urgent care setting?
Yes. So they are, if they were seen, a year and a half ago, and they come back in, they're still an established patient.
Right.
It's 3 years to become a new patient again.
Is it just that clinic, or is it any of ours?
It's any of your clinics. Yeah, it's any of your clinics. Procedures. So this is an area where we don't see a lot of issues with it, but I want to explain what we need to see. Every once in a while we'll see, X done by me and not a full procedure note. We need a brief description of the details of what you did. And the reason for that is we have to, assign the appropriate CPT code, so we need to figure out what was done. We don't need a big, long surgical note, but, brief how you performed it, the method, the approach, the anesthesia, the prep, the outcome. As long as we have that, we can pick it up. Then there's some procedures that require a little bit more because there's multiple different CPT codes for those procedures. And one of the things that we see, frequently with procedures is we can't quite figure out, let's say it's laceration repair, which I'll talk about that. It's really important, again, for those details, length of laceration, fracture care, the exact location of the bone of the fracture, because CPT has so many different codes for different locations on the bone. So it's again, this is where specificity and details are very important. There are circumstances that we can query it back to you if we don't have the information. And then, rarely will we just lose it, but it's delayed money. If we can't, if we just can't code it without the information, or it says something like, repair done by me, IND done by me, but we don't have details. We need those details. Was it simple? Was it complex? And we can tell that. You don't have to tell me whether it was simple or complex, but we can tell that by the type of documentation that you've done. Have you done hacking? Have you not? And that's how we determine what is the right CPT code. Ancillary services, EKGs, important that you document the interpretation. We need at least 2 elements. Now the rule on interpretations, what CMS says is that it is like that of a specialist in the field. So, what does that mean? So, if you're doing an EKG, how would a cardiologist document their interpretation? So what we're looking for is not just normal, EKG normal. That's not something that's going to be a circumstance that we can pick up that EKG. So we want at least 2 elements. Moving over to the pulse ox, again, same thing. We need the reading and the interpretation. A lot of times we'll see on the pulse oximetry just the reading and there's no separate interpretation. And this is definitely just in the urgent care in the ED setting. We're not billing for pulse oximetry. So give us the reading and the interpretation. If it's normal, that is the interpretation, and then we can capture that service for you. Any questions?
A question for you.
Sure.
Sorry to rewind a little bit.
No.
On the established patient versus a new patient, the different urgent care centers, if the documentation systems don't match, and so we don't have that information, and the patient doesn't pro-offer it, is this patient now a new patient? I mean, a month ago was seen in another urgent care center, not the one that presently is the patient's visiting.
So are all your urgent, so I guess a question then is, are all your urgent cares under the same tax ID?
He just stepped out.
Right.
Yeah, they are.
Yeah. And so what what we do on our side, in that case, that wouldn't be a new patient because you're in the same group.
Okay.
You're the same type, the same specialty, same group, so it's just a different location. If they didn't say, hey, I usually go over to Sierra and, you know, they're at White Oak, or it's going to be hard for you to know. On our end, we always run a system, we run it through when we put it into our system to see if it captures that patient, because that patient has, you know, multiple visits. And then from the coding so that's the billing software, and then from the coding standpoint, anytime that patient's been seen, we're able to pull up all of those visits, because there are times where we need to refer back to a visit, especially for some of those follow-ups. Let's say it was a laceration repair. So if it's not caught here, typically it'll be caught on our end.
Okay.
We have different documentation system, EMRs in different sites. So it'd be impossible. It would take a lot of, you'd have to open up the software in a separate thing. I mean, does it matter, or?
No, as long as we can find it, and again, the patient comes in and the patient has identifiers that we pick up on our end. So that patient, let's see, they were seen at three different sites, all within 3 years. That first visit, the patient's a new patient. Say a year later they come into a different site, and you might have them as a new patient, but once we put them into our system, it's going to flag that, oh, wait a minute, we've seen this patient before, and we need to check it. So that's more on our side.
I'm thinking of a funny question. On exam nowadays, I can draw the system or possibly take a picture instead of detailing the findings. You look at these.
So I have never seen a picture in any of the records.
I mean, it gives the option to upload a picture, actually.
Really?
Never did it, yes.
We've done it. We've
Yeah.
done it in urgent care.
We do
Yeah,
other lacerations, there'll be a hand with wherever the cut is and
Uh-huh.
the stitches on there.
I have never seen, and you know, obviously I haven't looked at all of your charts, but in everything that I've looked at, I haven't seen any pictures. Now, what would a picture do from a standpoint of coding? For a laceration repair, it's not going to mean anything to us, other than it's kind of interesting to look at, because we need the details of the laceration, you know, the length and all of that. From an exam standpoint, again, a picture, if you gave me an example of, you know, maybe it was the skin, there was a you know, dermatitis or something going on, unless you actually put words to that picture, again, we wouldn't know what to do
No,
with
you
it.
do some word, but the picture helps, you know.
Would it make coding more interesting?
Absolutely. We like pictures. It would definitely make the coding of it more interesting. But I don't think that we could count anything for it, because I certainly couldn't interpret the picture. But sure, we wouldn't mind looking at them. So fracture care, moving on to fracture care and splinting. So anytime a patient comes in and you're treating for the fracture, and this is non-reduced fractures as well. There are codes for manipulation and reduction of fractures, and then there's also codes for non-reduced fractures. So, you know, a toe fracture, you buddy tape the toe. Even if the patient goes, you send the patient to ortho, what else are they going to do? As long as you're doing the definitive treatment of that non-reduced fracture, we can capture that fracture care. So this is where it's important. And that's not something that, you know, you have to remember, okay, which ones qualify. As long as you document everything that we need, we can determine that. So for fractures, CPT has, again, multiple different codes for different locations of the fracture on the bone. So a distal radius versus a proximal versus a shaft. It's really important for you to give us the details. And then, you know, did you do any reduction or manipulation, stabilization, and follow-up? So for those non-reduced fractures, that toe that's fractured that you buddy tape, you document where the fracture is, you buddy tape the toe. We could bill for that fracture care. So again, really important to give us the details of that. Splinting, this is another, let's say we have a distal radius fracture that you splint, but it's swollen, and you know that that's probably going to need casting a couple weeks down the road. but you do the splinting here. We're not going to charge for that fracture care because you haven't done the definitive treatment. It still needs some other treatment to heal. And whereas that toe fracture, you buddy taped it and it's good to go. That's, you know, they're not going to put a cast on the toe. In that case, if you're splinting it, we can capture that code. So again, important just to document everything you're doing. If you're putting a splint on, let's say it's a finger laceration, and you want to protect it, you know, there's circumstances where those aren't bundled together, meaning we could actually build the splinting as well as the repair. It's not always. It depends on the payer and the situation. But the point here is it's really important that you document what you're doing. As simple as a splinting a finger, document that, and there's opportunity for us to pick that up. We can capture it if you personally apply it. We can also capture it if maybe the medical assistant's putting the splint on, and then you go back and you check for post-application. You're checking for neurovascular, distal neurovascular status. As long as you document that, we can capture that as well. So again, really important just to document the details of everything that's being done. Here's a picture. Laceration. We like pictures. So this is important. Details, details, details. Again, what we see missing, not as frequently as we used to. I think you're all pretty good at it, but we really need the length of the laceration. There's different categories of repair, so the details are important here. Otherwise, you know, it might be an intermediate repair, but you haven't documented all the details, so we capture it as a simple repair. And an example of that is a simple repair is just a single layered closure, where an intermediate repair is a multiple layer closure, or it could be a single layered closure where you've done a debridement. You know, let's say kids skateboarding and falls and has a bunch of, you know, rocks in his knee, and you're picking out the rocks, or, you know, falls on glass, you're picking out the glass, but you're doing a single layered repair. That then qualifies for an intermediate repair. You know, heavily contaminated wound, if you're really, you know, cleaning it out like crazy, document those details, and that even though it's a single layered repair, which would normally be simple, it turns into an intermediate repair. Complex, we don't see a ton, but that's a more than a layered closure. So if you're going into muscle, that qualifies for a complex repair. You know, doing any extensive undermining, again, don't see a lot of that, but it just goes to show the importance of the details. We need the length in centimeters, so tell us the length of the laceration. If there's multiple lacerations, so you have one on your right leg, one on the left leg, maybe one on the arm, give them to us separately, because there's also with CPT, the different body areas get grouped together. And they could be, you know, one could be simple, one could be intermediate. We'll break them up and code them appropriately, but it's important for you to give us, don't just say, you know, three lacerations, total 12 centimeters. We're going to have to kick that back to you. We need them separately so we can put them together. So like a forehead and a scalp are two totally different codes. So if you've got, you know, a forehead laceration and then a scalp laceration, and you know, altogether it's, you know, 6 centimeters, we're going to have to send it back because it's two different codes. So again, details really important there. And that's it. Any questions? Okay.
Go ahead.
This is an assumption I've been making, and I hope it's not a bad assumption for the last 10 to 15 years. The single layer, that epidermis and dermis is one layer?
Mm-hmm.
Okay, so like a full thickness laceration, but not into any subcutaneous tissue?
Correct.
It's just one layer?
Correct.
Okay, good.
Correct.
All right.
That was a good assumption.
Thank you.
What procedures are urgent care appropriate, reimbursement-wise, etc.?
So from a coding standpoint and a documentation, you know, reimbursement standpoint, any code within the CPT book, a provider, whether MD, PA, NP, is able to utilize. That question is more of scope of practice. So there aren't any codes. I mean, you could technically do critical care in the urgent care. You
And
know,
all insurances that we pay for procedures that we do in urgent care?
Absolutely. So it's, I mean, if it's within your scope of practice, then there isn't a, okay, we're never going to pay for this in the urgent care setting.
I know that some have a cap.
Pardon me?
Some insurances have a cap on payments, so.
Yeah.
So some of our, one of our urgent cares in particular is capped under, prime care.
Okay,
It's cap payment, we can do whatever we want, we get paid the same.
right.
So there are, this is in general with a PPO payer or something, I suppose. But some of our other contracts are capped, and it doesn't matter if you do everything or nothing.
Right.
You
So
get the same amount.
that's, right, so there's capitation. There's also with CMS for any physician extenders, mid-levels, they're paid at a 15% reduction on the evaluation and management service. So in the urgent care, you're not a high Medicare population, but you do get a 15% reduction. But as far as not being able to do any procedures and they just won't cover them, that's not the case. In the ED setting, it's a little different.
You know, from a practical standpoint, the patient comes in here, getting grown tornado, let's say.
Mhm.
Honestly, if it's worth spending, I don't know, half an hour to 1 hour just preparing, doing the procedure, is it worth it, or just tell them, go to your doctor to have it fixed? I want to know, you know?
I gotcha. So that's a reimbursement question, more so than, and that would be a fee schedule question. You know, the patient's coming to see you, is it clinically, does the patient need that? I mean, that's not something that I can really answer. I can let Dr. Parks, you know, look at the fee schedule and maybe he could answer that for you.
You know, we've talked about this, and at the end of the day, we want our providers to take care of patients. And, you know, we've had a few examples. You know, somebody comes in short of breath, critical. I mean, we're not going to check their insurance and collect their copay before we start taking care of the patient. So I feel, and you know, I'll speak for Parks on this. No, you know, if you're taking care of the patient, that's paramount. And so I don't think anybody's going to come back and be frustrated as long as, you know, hey, we were taking care of the patient. And it can apply sometimes to non-critical issues too, like a toenail removal. We've actually, Leila and I were just talking about this issue. It'd be nice if we weren't an urgent scare, you know, where we just kind of take care of only the easy things and we're just chirping everything else back to the PCP or to the urgent care. I mean, if a chest pain comes in, we should be doing a quick EKG and vitals and then deciding, yes, onto the ER or not. You know, we continue hearing little stories here and there where that's not happening. Somebody comes in short of breath, chest pain, oh, send them right to the ER. You know, that person might have been better off going in an ambulance or this, that, or the other. So I know I've kind of opened a can of worms and given a few examples. I mean, we want you to take care of the patients. Whether it's a critical situation, whether it's a toenail removal, or whether it's a quick triage and we put them in an ambulance and send them rather than send them by private auto.
You came 5 minutes before 8.
Right, and well, that's my other point. So as far as reimbursement and things like that, if Physician's Choice is getting back with us and saying, wow, you guys are doing a lot of this procedure and it's not well covered, maybe we'll come back and do some coaching and change our policy. But as far as reimbursement is concerned, we don't want that to be a rate limiting factor to treating patients. As far as when patients come, I would hope we're not in urgent care that change, you know, just because it's 5 minutes to close, we decide not to do a toenail removal. We want to try to get providers to create an environment where those things get done, whether they're the first person to show up in the middle of the day or the end of the day.
Yeah.
That's easier said than done. I mean, in practicality, it gets busy. That's why we try to provide double coverage and things like that so that we do give our providers time to take care of the needs that the patients are coming in with. So that's kind of my thoughts in a nutshell, Kevin.
I agree 100%. You gotta take care of the patients, and unfortunately, if it's 1 minute to 8, and they need to have a procedure done, you do it. That's where they're there. This isn't an office. It's not, door doesn't close at 5 o'clock. You know, we're somewhere between the ER, which a lot of us live in as well. They walk in 30 seconds before your shift is off, then you're stuck. It's just how it goes. So we got to do what's right for the patients. Having said that, if the other part of your question was, what about some of these other procedures? If somebody comes and says, oh, by the way, I need this and that, you might just ankle, and can you take this mole off for me? The answer to that is no. I mean, we can do that procedure, we could probably bill for it, but that's not what we're there for. That's, purely like a cosmetic procedure. And those type of things, if you have a question about, call us. Take care of the patient, take care of their urgent needs, whatever that might be, we take care of that. But there are certainly limits. We aren't doing dermatology, whatever.
Foley's came up, I don't think we have Foley's in.
We do, but the provider has to put them in.
Right.
Okay,
So
so,
if you had acute urinary retention,
We don't have it in, we only have it at the non-critical sites. At the critical sites, we don't have it.
okay, so we have them in some of our sites.
Yeah.
And if you're a provider, you can put one in, and that's what the patient needs, send it to the ER without suffering. Okay, but just make sure you know how to do it.
I had a osmosis with blockage, and I had to remove one, and we didn't have one.
And make sure you document it.
Yeah.
I had the thrombosis already, but I never did the surgeries.
If you haven't done them, don't do them. I mean,
yeah,
there's-
that's a
and
good
if something,
example.
if there's something that we need to do some training on, we can do that. We do a lot of thrombosed hemorrhoids at the ER. I mean, certainly something we can get confidence in, but if you aren't, I prefer you don't do it. For sure.
I'm all for procedures, so if you want to do your procedure clinic, let me know.
There you go.
Okay, yeah, we'll do that.
I just like to be able to extend the services I can provide, in my knowledge base.
But we have only one standard laceration kit. We don't have any other thing there.
What's that now?
We have only one preset laceration kit. I mean,
That's all we
certain
have.
procedures we need other tools. as
That's
well.
all we have in the ER.
Like,
We do all this. We have one kit, we have a scalpel. That's it. You got 4x4s.
Okay, so this should be enough for.
there should be
There's
some
some head
alligator
spreaders, too.
forceps for, if you need to get something out of the ear, or, there should be some other basic things around it at the sites.
From
and
going
how-
to nail, I'm used to a freer that removes the nail initially, and maybe a donut tourniquet, things like that, but that's
Right.
we can go around.
And again, we can talk afterwards about, the toenail removal and how to adjust, but I appreciate your question, hopefully that's, any thoughts else?
Any other questions? Anything I didn't cover that you had questions about? I know that documentation and coding is so exciting for all of you.
I don't know if you know the specifics of how PowerWorks appears on your system when you, so that you can see the coding. Like if the MAs document what ACE route they use to put on the splint or something like that, can you see that?
So we do, if they document the size, yes, we can see it, and that you bring up a great point. As long as it's documented, let's say it's not documented, the size isn't, they forgot to document it, we'll still pick it up and we'll still code it, but it goes down to the lowest level. And it goes, so as long as they're documenting it, we'll pick it up. Same thing with meds. There's some sites that dispense meds that we capture, and it's important if you're giving injections and infusions that, we know the route, how you gave it, what the med was, how much, and we capture that as well.
Because yes, we don't put that part as a
No,
priority.
we get your entire record.
Okay. And then for the splints, we have to put, because I just put custom, I put the type of splint. So fiberglass, but you also need the ACE wrap size.
The ACE wrap size, yes. Because we're capturing the ACE wrap as well, and so there's a different code for the different sizes.
Can you bill for these reps?
Mm-hmm.
That's funny, because the hospital complains bitterly because they say they can't bill for these reps.
Well, they can, depending on
What they decide to do.
yeah, what they decide to do, and it's not always reimbursed, and so that's the other piece. There are a lot of things that we can bill for, but if we start to see that it's just denial after denial, and we obviously fight those denials, but there's some that just, you're you're knocking your head against the wall. At that point, we come back to you and say, you know what, if it's really hard to give us the size of the ACE wrap, forget about it. But what we do is, what happens today is, there's 3 different codes for different, widths of your ACE wrap. If we don't have it, we'll just go to the lowest, because it's not, it's not huge dollars. It's not like the difference between a simple and an intermediate laceration. For that, we're gonna kick back to you.
Are I think the last time we did this, there was a discussion about the custom split, like talking about just put a piece of fiberglass build better than the preform split.
Absolutely.
And it's way cheaper for us. They keep ordering all these crazy customs or these crazy preform splits, like, oh, there's a wall.
Yeah, it does, it absolutely does, because there's more work involved. There's some peers that if it's pre-dental, that they won't even pay for it. There was no.
So Kevin, are you saying to have it
Do that online.
Get rid of all those preform splits, every single one.
Let me just send it back to the
I don't know, maybe.
Yeah, because the hospitals, more or less, we have a lot of, prefabricated houses, splinting and all of that, and sleeves and all of that. And then, as far as ear robotics, it's the same thing.
We'll catch up.
Provided
You call tonight, tomorrow.
Correct. Correct. So it's the only thing that we weren't paid for was like that summer work and everything else. Except for you're documenting it. Ear lavage or any procedure that you actually need to be doing it.
And you guys actually do the charts. They don't give it out.
And there's some sites that actually have codes on them for us. We read through the thing and try to capture everything that we have. But you treat high grade, and it's more on the establishment.
Especially if you're doing it, a lot of others can share. Are we, are we in the ballpark? Do you think that'd be?
You know what, I'll have to go back and I'll do a comparison. I couldn't tell you just by doing a chart review.
Right.
It was nice meeting you.
A little bit new with the group, but I did it very concrete and said, I'm gonna come out with the charts and figure out what the issues are. Whether or not there's do a lot or better, I think run some reports.
Yeah, it's kind of interesting. So we're trying to, especially with us struggling we're trying to put our energies where they kind of most good.